Hello there, it's Dr. Verlage again with our next lecture in our series. Let's just do this. So today's lecture is about bridging the gap, workforce development and training in perinatal mental health. Now, I'll tell you in advance that I focused mostly on training and the providers for medication management. Obviously, there are many other components to women's mental health and perinatal mental health that include therapists, social workers, doulas, lots of different members of a treatment team. But again, this is mostly on psychiatric medication management and what that workforce and training looks like. So, the group of providers that I'm going to talk about first and what training for perinatal mental health looks like for them are physicians, medical doctors, or doctors of osteopathic medicine. This might be knowledge to you guys already. MD and DO, the training quite similar, the standards also quite similar. We're talking about a 4-year medical school and then a residency, which can change in the number of years depending on the specialty, 4 years for psychiatry, but in my mind, pretty equivalent. So these are, say, the most highly trained providers that are going to be seeing patients. So I was actually looking at the specific requirements for perinatal training for residency, of which I was not able to find anything. So in a 4-year residency for psychiatrists, there's, you have to do a certain number of inpatient rotations and outpatient rotations. And even they do have a specific requirement for child and adolescent psychiatry. You have to do 2 months of that. But outside of that, it's up to the discretion of residency programs what their other requirements might be. My residency and others that I've heard of do not require that you do a dedicated perinatal psychiatry rotation. Now, usually you meet weekly to do what we call didactics, going over studies, lectures, different topics. And most didactics will include at least some amount of lectures about perinatal psychiatry in those lectures. But I'm trying to remember, through our residency, it was maybe 2 to 3 days of dedicated lectures. So not too much. Now, you could imagine that 4 years of seeing patients under supervision, you're not gonna, it would be really, really surprising if you never saw a patient who was pregnant. So you will inherently be exposed to working with pregnant patients when you're seeing patients for that long. And so hopefully learning can happen on those occasions. But those are, the technical requirements and training that a psychiatrist who is an MD or DO will have, any MD or DO will have received. Now, you can pursue more specialized training in perinatal psychiatry. I'll talk about tracks, which is what I did in my residency. So a lot of residencies will offer these specialized tracks that you pick to do during your 4 years in residency. And basically, if you do the track, you're expected to do a number of rotations in that specific thing. So I did the women's mental health track. Now, this didn't only deal with perinatal psychiatry, menopausal issues too, menses related things. So anything kind of what we call across the reproductive lifespan. But I would say heavily leaning on pregnancy and postpartum. Most of my rotations were that. So for example, I did rotations, working with OBs at high-risk clinics on their psychiatry days, working in a postpartum specific clinic where patients from other clinics would be referred if they were in the postpartum period, running a women's support group, And then I had my own mentors, dedicated didactics, that I would just meet with them to discuss papers. We even completed some of the trainings that I'm going to mention in a little bit. But yeah, it's more tailored to this population. I think it's kind of disappointing that we don't have a requirement for general residents. It was surprising, again, that yeah, most of them are going to be working with pregnant patients at some point. And, I think at least having some of these rotations done is an important part of an education, but like we said, not a requirement. So I looked up, apparently a lot of programs have this kind of track or system, again, during residency, during the 4 years of that residency. So I went to UT Southwestern, but I saw that University Hospital in Cleveland has it, Baylor College of Medicine in Texas has it, and many others have it too. So then the next level is, which was new and maybe not really offered that much when I was in residency, but they've really, come up a lot in the past couple of years, is dedicated fellowships, which is you complete 4 years of residency and then you do a fellowship for a year after residency. And these dedicated fellowships for women's mental health. There's at least nine in the country. These are growing. Now, mind you, fellowships usually have spots for maybe 1 or 2 fellows. So when we think of like a volume perspective, not pumping out a lot of providers, but these will be very well-trained people who have done, again, some pretty dedicated time working with the population. I think this is an important thing to cover, which is the training that, from a volume perspective, probably is the most relevant. So there's a group, the Postpartum Support International, has created a certification to say that you've trained and specifically for perinatal psychiatry. Now, it can be online or in person. We're talking about 14 plus 6 training hours. So, when you compare it to maybe some of the other ones we've talked about, not as much, but you can cover a lot of ground in that time if it's, again, pretty dedicated. And so that's when you see denoted a PMH. So a lot of NPs will get this and put this at the end of their training. This is what they're talking about, is this 20-hour training that helps learn some of the, specifics about working with perinatal patients. There are also, continuing medical education or CME credits that, any psychiatrist needs to do in order to remain board certified. I should say psychiatrist or nurse practitioner. And, there's specific CMEs that you can get that help you learn about, perinatal psychiatry. However, it's up to the discretion of the provider what kind of training they're looking for. So it's offered if they want to learn more about perinatal psychiatry, but it's not a requirement to pick that one specifically. Obviously, I would hope that, if providers encountered enough patients where they felt kind of out of their depth and wanting to learn more, that they would pick to pursue these CMEs. But again, not something that is a requirement for them. So 2 examples, the National Curriculum in Reproductive Planning, NCRP, offers a really great course. I also did that course during residency. Massachusetts General Hospital modules, I've done that one too during residency, or I think I did that the year after residency. But yeah, these are some resources and CMEs that providers can go to get a little more training. Okay, so let's move into the a report that was published looking at this group was the Policy Center for Maternal Mental Health, and this report showed that there's a worsening crisis in maternal mental health across the US. So fortunately, on the good side of things, there has been more training for maternal mental health providers, or MMH. However, the risk for maternal mental health disorders is rising. And another important piece from the report is that there's a huge disparity in, access to resource, or those resource gaps, especially in specific regions, which we'll talk about in a little bit. Now, I thought it would be also good to include that the way that this report classified a maternal mental health provider, we just talked about all the things that you could consider a maternal mental health provider. But the one that they're looking at is specifically the, the PMH, that one that can be included, the 20-hour course. We'll go into the numbers. So if we think about, how many fellowships there are, I said that there were 9, and you can get 2 fellows in a year, right? Or something like that. So we're talking 18 in a year of graduating perinatal psychiatrists with that fellowship. If you loop in the residents like myself who've done the track, you may be able to include maybe 2 residents a year and all these residencies, and there's, I think, about 2,000 graduating psychiatry residents a year. Not all of them are doing the track. We're maybe talking about another 100 to be, really, gracious in that, versus, which we're going to talk about a little bit, the number of providers who were doing the PMH training, the 20-hour training. So they defined MMH as the ones who had completed the 20-hour training when they were doing all of this. So that shows us here. So the providers who did the MMH, who were MMH providers, more than doubled between 2023 and 2025 from 4,000 to nearly 10,000. So again, we think about the numbers of providers who've done either the track or the fellowship. They pale in comparison to the ones who've done this training. And even with this training, which yes, is less rigorous, but even then there's a huge, shortage of them. But just from bang for your buck, we'll be talking about these numbers specifically for the rest of this presentation. So huge growth, that's great. We've got more providers who were trained. However, growth was more common in lower risk areas. So most of the providers that got this training, again, that doubled, they do tend to cluster in metropolitan areas, which have still, needing more providers, but they are the lowest risk of the maternal mental health risk. So just to really shed light on how much of a problem we're in is that the amount that we would need to close the gap of what's needed and to cover all the patients who need that help is an additional 9,500, which isn't totally unrealistic given the rate of increase between these years. But I think which this slide goes into, these dark zones of shortages, which is high need, very low amount of providers available. So these dark zones that they call them were the highest risk counties, and they showed that the dark zones did slightly decrease, again, 157 to 146 counties in America, but we're still talking about 84% of birthing aged women still, again, this is across the country, still live in areas with shortages. They list some of the states here that are struggling the most. I looked up, they didn't have the specific numbers for Montana, but we do know from plenty of data that, we are not on the we have enough providers end of things in Montana too. So this report came up with a number of recommendations. So one, to invest in holistic support, so increasing funding for things like family resource centers and community-based organizations in those high-risk counties that they identified. Something that we all want, expand healthcare coverage, so ensure that there's comprehensive healthcare access for these women, including mental health services that we should follow with up to a year after the birth of a child. And then getting insurers to cover more than what they do, and they mention this in the next slide too, but a diverse set of mental health therapies. So therapy, group therapy, obviously meeting with providers that can manage medications. But yeah, expanding the mental health front on multiple aspects of care. They also recommended to establish task forces to kind of help figure out how to get these resources to these underserved populations that are tailored to local strategies, which I think Montana is really taking seriously, and you can see that in all the programs that are being run and all the work that's being done to try to get more access to areas of the state. Here's the shout out for what I do, and something that they specifically talk quite a lot about in the report is psychiatric consultation. So what that is, again, probably beating a dead horse at this point, but what I do is when an OB, when a family medicine doctor, when anybody who is managing medications or part of the treatment team of someone who is pregnant or postpartum needs advice, needs some help with direction and diagnosis and whatever with somebody who is pregnant or postpartum, you talk to me, a psychiatrist who has specific training in the population to help guide as to what to do. That's really, a great way to get specialized care to as many people as possible. I looked up that currently 25 states have this type of setup, these consultation lines. 2 states are in the works of getting it, up and running. So it's something that probably will become standard for most states, just because, again, especially if we can get traction with it and get enough people using it, it can really make a huge impact on women getting the care that they need, specialized care that can make a huge difference in their experience. And then more of a complaining, which I also complain with, insurance coverage, also covering doulas, postpartum health, home health nursing care. I can't even think about the number of patients who could have really used that support during their pregnancy and postpartum. So, I think that, this was helpful for me too, to tease out all these numbers and read, this report and differentiate the different trainings that there are and how we define them, so that we know what we're talking about when we're talking about providers who have that training and how much we need them and need more of them. So with that, I will finish up the presentation and see you at the next one.